Assalamu alaikum wa rahmatullahi wa barakatuh. Ladies and gentlemen, it's an honor and pleasure for me to be with you virtually, and I'm sorry for not being able to be physically there. And I'd like to thank the organizer for inviting me. The task being given in the next 10 to 50 minutes is to talk about what I feel is of interest in HFrEF in the last year. So what I'll be talking about, I'll talk about the new role of SGLT2 inhibitor in HFrEF, how early we should initiate guideline-directed medical therapy, and how many of these we should give, the change in the chronic HFrEF treatment pathway from 2017 to 2021, the value of screening for and treating iron deficiency in HFrEF, the updates in the atrial fibrillation management in HFrEF patients, and how do we manage secondary functional mitral regurgitation in HFrEF patients, particularly the role of mitral valve clip percutaneously. And we'll be discussing briefly is the issue of persistent or absence of residual risk if we apply all the available guideline-directed medical therapy. And we'll finish off by talking about VRISquat and omecamtiv mecarbil in worsening heart failure. What do they offer? You know, SGLT2 inhibitors are diabetic medications. They inhibit the reabsorption of glucose in the proximal tubules, therefore improve your glucose control. As per the FDA regulation, all new diabetic medications have to show that they are safe in high-risk diabetic patients. And these agents did show that they were safe as far as reduction of cardiovascular death, non-fatal MI, non-fatal stroke. But surprisingly, they showed significant reduction of heart failure hospitalization. That was a surprise, nice surprise. The logic following that is to see whether this agent could be used to treat heart failure. And I will talk briefly about the two big landmark trials in HFrEF patients, the DABA heart failure and the EMBRA-REDUCE. They are very similar trials, enrolling between 4,000 to 4,700 patients, HFrEF patients, ejection fraction less than 40%, diabetic or non-diabetic. A lot of them have CKD, comparing DABA or EMBA against placebo on top of optimal guideline-directed medical therapy in HFrEF patients. And the two trials were very similarly positive, with a relative risk reduction of 25 to 26% of the composite endpoint of cardiovascular death or heart failure hospitalization, with the number to treat is only 19 to 21. So these drugs, out of the blue, diabetic medication, they were not on their radar of heart failure 2-3 years ago. Now they jump to the top of the chart and become class 1A recommendation in the management of HFrEF, in top of what we already know and we use, the beta blockers, the MRAs, and more recently, before the SGLT2 inhibitors, the ARNIs. So we had 4 new good drugs. The questions, how early we should use these drugs and how many we should need or should give. Regarding the how early, it is as early as possible. Why? One of the reasons that we know that people who get discharged after admission with acute decompensated heart failure, the mortality is highest when? In the first 1 month. So if you not start this medication during hospitalization was early in the first week or two, you lose a lot of patients because you didn't do what you are supposed to do. And we also know, even before the era of SGLT2 inhibitors and ARNI, that if we give all the triple therapy, the ACE, the beta blockers, the MRA, the survival 1 year is 90%. But if you defer aldosterone antagonist, you reduce the survival by 3%. If you defer the beta blocker, you reduce by 4.8%. If you defer the ACE inhibitor, you reduce by 4.4%. So basically, the more you defer, the worse is the prognosis. Regarding the issue of how many, the more the better. So if you give, say, ACE inhibitor ARB only, yes, you do better than placebo regarding cardiovascular mortality and heart failure hospitalization, but the more you add, the better. And if you top it with giving ARNI, beta blocker, MRA, you do much better. So the more the better, the sooner the better. And this was highlighted in the recent last year new guidelines, European Society of Cardiology guidelines, where they revised the pathway of management of HFrEF from that of 2017, 2016. The old pathway was good, nice, involved guideline-directed medical therapy, fine, but it was sequential, stepwise process. You start with ACE inhibitor, beta blocker, and then review the patient. If they are not well, you add aldosterone antagonist. If they are not well, you switch to ARNI from ACE inhibitors. And then if they are fast, you get it's smart beta blocker, you add ivabradine, and consider hydrolyzed nitrate in Black American and ICD if their ejection fraction is poor. If they white QRS, you put CRT. So this takes months and months and years. We'll end with a lot of patients not on optimal therapy even after 2 years, and a lot of patients you'll be lost by the time. The new guidelines from August last year, European Society of Cardiology, recommend that we should all use all the 4 pillars, the RAS inhibitors, the beta blockers, the MRA, the SGLT1 inhibitors, as soon as it is safe to do so. And it recommends that sacubitril/valsartan should replace ACE inhibitors. The American went a step further by saying that ARNI should be used instead of ACE or ARB, and ARB should be used only if ARNI is not tolerated or cannot be afforded. The issue of iron deficiency anemia in HFrEF patients has been recently highlighted in the HFrEF acute heart failure trial, which basically screen patient admitted with acute decompensated heart failure, ejection fraction less than 50% for iron deficiency, regardless of presence or absence of anemia. Hemoglobin can be up to 15, as long as they have low serum ferritin and or transferrin saturation, and randomize them to intravenous carboxymaltose or placebo and follow them for 52 weeks. And those who received carboxymaltose did much better and with significant reduction of heart failure hospitalization. And now it's class 2A recommendation that you should screen and treat iron deficiency in HFrEF patients. Regarding the AF, really, the update is really the highlight of the importance of rhythm control. We should aim for rhythm control. It is actually class 2A recommendation to consider pulmonary vein isolation in HFrEF patient with atrial fibrillation. And if you can't, then amiodarone to keep them in sinus rhythm. And for those who remain in atrial fibrillation but have fast rate control that you cannot control maximum tolerated heart rate lower medication, consider ablation of the AV node and CRT implantation. And anticoagulation should be considered in all heart HFrEF patients in atrial fibrillation, regardless of the CHA2DS2-VASc score. And moving on to the issue of mitral regurgitation, which is quite common functional mitral regurgitation in HFrEF patients, which a lot of people just presume it's because dilated LV, we cannot do anything about it. Now, the recommendation that once you put the patient on maximum adequate therapy, including CRT if appropriate, revascularization if needed, and provided they fulfill the co-opt criteria where the LV is not very dilated, less than 7 centimeters, the ejection fraction not too poor, more than 20%, they don't have severe pulmonary hypertension, then it's class 2A recommendation that you should consider percutaneous repair of the mitral valve with mitral valve clip. Now you can do all that. If we do all that, you give them the best treatment, clip their mitral valve with regurg, whatever. Have we cured the problem? Has the risk gone, or would there still be a residual risk? Unfortunately, there will be still residual risk. And we know that from, say, the Paradigm trial. The group who are on the ARNI, which did much better than enalapril, still 21.8% of them get readmitted or die within 27 months. And in DABA heart failure, similar thing, the group on the DABA, the better drug on top 5 maximum therapy, better than placebo, still out in this group, 16.3% get readmitted or die within 18 months. Similar thing in the IMBA group and the IMBA reduced trial. Therefore, we're still in need, we continue to be in need in new strategy, new medication, new devices for this poor group of HFrEF patients. And we have 2 promising agents that we'll talk about, the vericiguat and the omecamtiv mecarbil in this regard. And the mechanism of action of vericiguat is unique. It works on the nitric oxide soluble guanylate cyclase GMP pathway. We know in heart failure, there's endothelial dysfunction, oxidative distress, lack of nitric oxide, inhibition of soluble guanylate cyclase, and reduction in the production of cyclic GMP, which has the bad effect on remodeling, thickening, stiffness, sodium and water retention. So what vericiguat does is stimulate soluble guanylate cyclase, makes more nitric oxide available to produce more cyclic GMP, which gives us all the good things. This has been studied in a large study called the Victoria trial of 5,050 patients patients with worsening heart failure with ejection fraction less than 45%. The definition of worsening heart failure in this trial is being admitted with acute decompensation within the previous 6 months or needed IV diuretic in the previous 3 months, and compared placebo to Verisquat 2.55 for 10 milligram on top of guideline diuretic medical therapy available at that time. And the study was positive with 10% reduction, relative risk reduction of cardiovascular death or heart failure hospitalization. And more importantly, it is 4.2% absolute risk reduction with the number to treat at 0.4. Therefore, the FDA has approved the use of Verisquat in patients with worsening heart failure. And in the European Society of Cardiology guidelines of August last year, and for the first time, the worsening heart failure itself has been recognized and been mentioned, and Verisquat being recommended as class 2B recommendation on top of guideline direct medical therapy in patients with worsening heart failure. Now, the other agent is omecamtiv mecarbil. This is very interesting. This is an active, positive inotrope given orally. It stimulates cardiac myosin. And this has been studied in a large trial called Galactic Heart Failure Trial of more than 8,000 patients, either during hospitalization or within 1 year of being admitted with acute decompensated heart failure or attending an ER or emergency department with decompensation. And comparing omecamtiv mecarbil against placebo on top of guideline diet medical therapy, and the study was positive, showing modest relative risk reduction of 8% of the composite endpoint of cardiovascular death or heart failure hospitalization. And the benefit was best seen on those who have ejection fraction less than 28%. So in summary, ladies and gentlemen, in this very short space of time, my take-home messages is that basically in HFrEF patient, it's important to initiate as many of the 4 pillars therapies as soon as it is safe to do so. ARNI should be used in preference to ACE inhibitors or ARBs. Routinely, we should screen for and treat iron deficiency anemia in HFrEF patients. In atrial fibrillation, anticoagulate and aim for rhythm control. You need to look for patients with significant functional mitral regurg. If they fulfill the COAPT criteria and they are symptomatic, consider referring for mitral valve clip percutaneously. Verisquat may be considered in patients with worsening heart failure despite guideline diuretic medical therapy. Omecamtiv mecarbil may have a role in patients with worsening heart failure who have ejection fraction less than 28% in sinus rhythm. And I'd like to thank you and look forward to the questions. Thank you.